there's no body system that's not affected by calcium. Look at the resulting signs and symptoms. So let's begin with cardiac. This is hypokalemia. Potassium level is low. Look at the results. You get PACs, palpitations, you have dysrhythmias, and then hypotension, because this directly affects the contractility of the heart. So this results in a weaker ventricular contractions, resulting in low cardiac output. And in severe, look at what happens. The patient goes into cardiac arrest. So VFib is the most common dysrhythmia found in cardiac arrest, either VFib or ventricular tachycardia. Respiratory symptoms, so it affects not only cardiac muscles but also skeletal muscles. And remember, your diaphragm is a muscle. So if your potassium level is low, that muscle is also weak. So you will have hypoventilation, respiratory distress, and also go into respiratory arrest. Let's go now to the other skeletal muscles. So your legs specifically will have weakness, cramping, paresthesias, and overall decreased muscle strength. Smooth muscles will also be affected. Look at your GI tract now, which are smooth muscles. So if you have low in potassium, peristalsis will also be slow, resulting in constipation, nausea, vomiting, and even prolonged gastric emptying, which can affect diabetics. Let's go now to management. You have a huge safety alert there. When giving IV potassium, because you can't give IM or sub-Q potassium, so potassium is either given by mouth or intravenously. So what does this safety alert say, Miss Vivian? Or Miss Decker? Thank you for reading.
Do you want me to read the whole thing?
The safety alert.
Administration of IV potassium is considered a high alert medication. Potassium is never to be administered as an IVP bolus. Total maximum 24-hour dose is 150 MEQs. An infusion pump must be used when administering IV potassium.
All right, so what have you learned there? Never give this thing IV push. There is an exception if you work in corrections, for instance, on death row. If you're trying to execute somebody, yes, we do give potassium IV push. Of course, we give them sedative first. We give them a muscle paralyzer, and then as soon as they're unconscious and paralyzed, then we give them the lethal dose of potassium. So that's only used for execution purposes. Yes, ma'am. Sir.
Oh no, that's what I was gonna ask you. That's what they actually use when they're doing the execution?
Yes.
Potassium?
Uh-huh.
Oh wow. Oh.
Okay, so yeah, if you work in corrections and you like that kind of work, executing, killing somebody,
Nah.
you commit, you commit murder.
No, thank you.
Hate you for it, right? And you don't go to jail.
I'll pass.
PO, it's fine. You can give.
Isn't that the same thing when you give the patient like the morphine before they pass in the hospital?
What do you mean for assisted suicide?
Yeah, no, like if the patient is like on their last stages of life, and then
no, that's not true. That's not true. Okay, you're bringing back memories here. I know what you're talking about. The first time I was a new nurse. It's probably it was my first yeah, toward the end of my first year in nursing, I had very good hopes, right? So I'm so proud to be a nurse. So I was excited about my practice, and I really only had a few deaths at that point. You probably had two or three deaths, and they all involved DNR patients. Like when you walk in, they're already dead. So it wasn't um, as meaningful as the first one I did. So this patient was also end of life. I already saw her doing the um, chain Stokes respirations. You know, I know they're about to go.
Yeah.
And so I called the husband. So I called him, hey, sir, you might want to come, quick. So, because, you can, I think it's time. And then so he was, he said, oh, I'm on my way, I'm driving right now. So in between though, the patient looked very uncomfortable. She was grimacing. She looked like she was in distress. Okay, and I had the order for the morphine. I couldn't let her husband see her like that, looking very uncomfortable. So I got morphine, and then I was giving it to her. Slow IV push, just like I always do. And then so she was comfortable. Okay, and then I was getting her ready. I cleaned her up. That way she's presentable when her husband comes to say goodbye. And I would just went to turn her because it was time to turn her on her right side. And when I turned her and put the pillows on there, she just stopped breathing. And I called, a second nurse to pronounce because somebody has to witness you, call it. then and then as I was walking to the station, the elevator doors open, and then the husband came out. And you know what I had to deal with, explaining to him. And then of course he said, no, but you said she was still okay when you called me, because it didn't take long. He didn't live far from the hospital. And for the longest time, I would say 2 years, I could not bring to myself, I can't stop blaming myself. So for 2 whole years, I seriously believed that I killed the woman. Until the more I understood end of life, the more I understood how morphine works. It wasn't the morphine that killed her. All right. So if this happens to you, do not fall into that 2 year depression that I went through. Okay, so for two
Okay.
whole years, I wasn't feeling well at all. I was questioning whether is this the right profession for me? Should I continue? Should I look for another profession? So for 2 whole years, I was blaming myself. And then I didn't come to terms with it until I understood what morphine does, how it works, why it remains the gold standard for pain management, especially in end of life. Okay, so yeah, so don't fall into that trap. Okay, so you don't have to punish yourself unnecessarily. All right, going back to potassium. Remember potassium, which organ again eliminates this naturally?
The kidneys.
All right, so
The kidneys.
all right, knowing that though, what should you do before giving any potassium, whether it's by mouth or intravenously?
Check the
You
level.
check the
Check
potassium
the
level.
Check the
kidney.
lab value.
Check the heart rate.
Check the BUN and the creatinine.
Okay, that's the correct answer. Of course,
Hey.
yeah,
Mm-hmm.
because of course, that the potassium is low, because otherwise you wouldn't give it, right? So
Yeah.
you have
Right.
potassium ordered. Yeah, it's a given. You should know the potassium levels, because otherwise you wouldn't give it. But the other side of it is it has to leave the body. So if it can't leave the body, because again, 80% of the excretion is done by the kidneys. If the
Right.
kidneys aren't working, should you be giving potassium?
No.
No.
No, because the
No, sir.
problem would be the opposite. You go from hypokalemia to
To
now
hyper.
hyperkalemia.
Yeah.
All right. So two things you observe monitor is always, of course, you check potassium levels before giving it, and more importantly, before giving it, make sure your patient's kidneys are working. So the only way to see that is your urine output. Are they urinating? Or look at your BU and creatinine. Are they normal? All right, your limit here, by the way, especially IV, PO, it's okay. You can give 40 every 4 hours. It's safe. IV, though, you must never give more than 10 to 20 milliequivalents per hour. Okay, and never give it by gravity drip. It has to be an IV pump because this thing will kill your patient. If you give it too fast, they go into cardiac arrest, they're dead. All right, so ideally we should do oral route, but um, if the gives it IV, orders it IV, then you have to make sure your rate of infusion must not exceed 20 MEQs per hour. Okay, so you do your calculation. This usually comes in a 100 ml bag containing 10 or 20. So if it's 20, that means you infuse it over 1 to 2 hours. I'm actually not comfortable giving 20. Honestly, I've never given 20 every hour. I've always stuck to 10. I just don't feel comfortable. I mean, textbooks and even the drug books say it's 20, but whenever I administer these things, I stick to 10 an hour. It's safer. So you can imagine how hard it is to replace potassium because this is your limit. IV, you can only give 10 to 20 milliequivalents. And PO, this patient will have to be eating a whole banana tree in order to correct moderate to severe levels. Okay, it's that hard to replace it. So whenever possible, you prevent it from happening. If your patient's not eating, yeah, encourage them to eat. These are your foods. Okay, mostly dried fruits are high, or even fresh fruits. Raisins are very high in potassium. Oranges and bananas, but I doubt if NCLEX will still use bananas on the exam. They're tired of that, just like I would be. Watch digoxin toxicity. This is the #1 cause of digoxin toxicity because digoxin rides the sodium potassium pump, so therefore it needs potassium in order to enter the cell. So no potassium, digoxin can't enter the cell. They stay in the bloodstream, leading to toxicity. And these are your symptoms: anorexia, nausea, vomiting, dysrhythmias, visual disturbances, which are blurred vision, or they see halos around lights, or lights appear yellow. Those are the complaints. Let's go to hyper now. So this is equally fatal. So this time it's really high potassium level. We have different options to drop potassium. Oh, by the way, since your most threatening complications is cardiac problems, so you know that you can't fix hypokalemia quick enough. Okay, the patient will be hypokalemic for several hours before it will be corrected because you're limited. Okay, you can't give high amounts of potassium to replace it. So it'll be several hours before, even up to 1 to 2 days before you can fix this. So since the patient is at risk for dysrhythmias, what will be your safety action while you're in the process of correcting the potassium? You should put the patient on what?
A ventilator.
For potassium.
Cardiac monitoring.
Cardiac monitoring.
Oh.
So put them on telemetry. All right. Because look, all right, everybody knows IVP is IV push, right? IVPB, yeah, IVPB is IV piggyback. That's different. So you can give potassium IV piggyback, but never IV push. So it should be given slowly at a rate of 10 to 20 milliequivalents per hour. So you calculate what's in your bag, make sure they're only getting 10 to 20 per hour. The same thing for hyperkalemia. Although we have more effective means of removing potassium rather than replacing it, we have several options though. One is excretion. We promote the excretion of potassium. We also have shifting. You can also shift potassium from intracellular to extracellular. And those are the two approaches. So you either eliminate it, which is the best way, but it's slow. Okay, you can't really, only the kidneys can effectively eliminate potassium. So the other means aren't really that effective. So you can shift it though. This is the fastest way to do it, is to put potassium somewhere else. Take it out of the bloodstream, put it in the cell. Okay. So let's look at our choices. So one is you give potassium wasting diuretics, which are thiazide and loop diuretics. So no more, none of these, because this will increase potassium level. So you stop these, stop potassium supplements, stop beta blockers, stop these because these are all going to increase. Now we will now give, also decrease your potassium foods, including salt substitutes. Salt substitutes are made of potassium chloride. Although other brands like Morton salt has a non-potassium based salt substitute. And you know about, is it Mrs. Dash? Yeah,
Yeah.
they're not really that expensive. I mean, the cheap salt substitutes cost about maybe 99 cents. The non-potassium based salt substitutes cost about maybe $5 or $6.
So,
So you,
Professor, you're saying Mrs. Dash is good? Because that's what I just cook with.
I don't know what's in it though. I just hear about it, but read the label, what it's made of.
Okay.
Because if it's potassium based, you might want to make sure you have good kidney function. If you want to keep, I mean, you don't have to worry if your kidneys are working fine.
All right.
Okay, so the other, um, I won't test you on the signs and symptoms of referring to EKG changes yet because we haven't done the EKGs yet. But I will go back to chapter 8 when we get to module 8. Module 8 is now cardiac dysrhythmias, so we'll go back here, okay, to test the EKG changes. Interventions. So since we know the causes, then now we know how to get rid of potassium. So
wait, hold on. Oh, Professor, I have a quick question.
go ahead.
For the shifting, when you're trying to shift the potassium, like how exactly that they would do that?
Oh, right here. So we will give short-acting IV insulin with glucose. Of course, you can't give this by itself because IV insulin will drop the potassium. Here, it will shift potassium. It will cause potassium to enter the cell along with glucose. But because glucose also enters the cell, that means blood glucose will drop. That's why when giving IV insulin, it should always be given with 5% dextrose.
Okay.
So,
Alright.
oh, it's right here. Sorry. IV administration of 25 to 40 grams of 50% dextrose with short-acting insulin, which is regular insulin. So that will shift it. So that's the fastest way. But remember, this is a temporary fix. This is short-term only. I mean, it works really fast, but remember, it doesn't eliminate potassium. The potassium's still inside the body. It's just inside the
Just
cell. It
shift
will
it.
go out eventually. So when the insulin wears off, potassium goes back out.
Okay.
So you need to give another drug to eliminate it. So here's the elimination options. You give you give Lasix or bumetamide. This is Bumex, another diuretic. So those are loop diuretics. You can also give thiazides, although thiazides have a limit, meaning the more you give thiazide diuretics, the less they will eliminate potassium. So the most effective will be Lasix, the loop diuretics. But also remember that loop diuretics also excrete water. So you may develop another problem there. Okay, because here caution is required because it will cause dehydration. So another choice is to give this sodium polystyrene sulfonate, or brand name is KX-Late. You may hear nurses call this SPS. That's what they're talking about. So when you say SPS is sodium polystyrene sulfonate or KX-Late. However, look at this. Onset is slow, 2 hours, and takes full effect 6 hours later. So this is the slowest way you can drop potassium, but the most effective though. But just remember, it takes a long time. So for severe hyperkalemia, moderate to severe hyperkalemia, the interventions, if you're given all three orders, I would of course give this first. So give your insulin with dextrose, and then follow it with either Lasix or KX-Late. Okay. Again, remember this thing here, the IV glucose with insulin, is only temporary. It does not eliminate potassium. So you have to give something else to eliminate it. But at least this thing here buys you time. So because this thing is fast, look, it drops potassium within 20 minutes, but it only shifts potassium. All right, is that clear? So you shift potassium either by IV insulin with dextrose. It must be followed with a potassium eliminating drug. So SPS and or Lasix. There's another option here. You can use albuterol in a really high dose. Here, 4 times normal. And again, this is another temporary fix. It works within 30 minutes, gives you a 2-hour duration. The IV with dextrose is effective for 4 to 6 hours. So perfect. So if you give this first, follow it with this one. And then once the patient has a BM, because that's what this thing does, it eliminates potassium in the stool. Understand?
Yeah.
Are we clear with hyperkalemia treatment?
Yeah.
Yep.
Okay, and then the same way, of course, just like hypokalemia, you put the patient on a monitor too. Monitor and then give your insulin with dextrose, follow it with SPS or Lasix or this one first. Okay. And that's it. I'm not testing calcium and magnesium yet, so we'll skip that. Let's go now to the next item on your module is, let's go to diabetes insipidus and SIADH. Chapter 41. Page 879. All right. So this is quick. These two problems are a problem of the hypothalamus, particularly this is of course, the hypothalamus is controlled by the posterior pituitary gland. So diabetes insipidus is a deficiency of antidiuretic hormone, and as SIADH is a overproduction of antidiuretic hormone. So if a patient doesn't have antidiuretic hormone or doesn't have enough, what will be the patient's problem?
Fluid overload or edema. Oh no, sorry. You said You said if they do. Oh.
Okay, so since you don't have it, you will be peeing like a horse.
Yeah.
You'll have polyuria, massive amounts of fluid, urination, that will lead to increased thirst, and you'll be peeing also at night. I know an let's just say somebody I went out with long ago. She developed this, and while she was having it, she was like the dry as a bone, and she would carry everywhere she goes. She'd be carrying um, a big water jug. It's almost like a cooler, because that's what she's having to do. I mean, she has to keep drinking water to replace what she's peeing. So for a while there, she couldn't really go out much because of it's very inconvenient. Okay, finding a bathroom. Plus, we're talking about the Philippines here. Yeah, we don't have much as far as public restrooms. Okay, and um, public parks don't have the best looking bathrooms. Um, and you know the policy when you go into restaurants, you have to be a customer, right, to use the bathroom. So it was very inconvenient. So you're looking at a very dehydrated patient. That's why here, look at your BU and creatinine will be, what did we learn in chapter 8? A very dehydrated patient. So what will your BU and creatinine be?
Elevated.
Okay, very high. What happens to your urine specific gravity though?
Decrease.
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 Decrease because you have polyuria. So you're unable to concentrate
Yeah.
the urine. So as a result, the urine will be very diluted. It's like almost peeing water, okay, almost fresh water. But because you're very dehydrated, your serum osmolarity will be different. So urine osmolarity is low. However, your serum osmolarity is very high because you're very hypotensive and dehydrated. Look at your hematocrit. It will be elevated. Sodium levels, although you did not technically eat a whole box of Morton salt, but because your blood is so concentrated that it results in falsely high sodium level due to hemo concentration. Your blood is just so dehydrated, so concentrated that your sodium levels appear high. And the rest would be, of course, you have signs of fluid deficit. No, there will be weight loss, hypotension. Interventions now. So you're looking at a very dehydrated patient. What do you think we will do?
IV. Well, yeah, IV, or we could try to give them by PO, fluid PO or
Okay,
IV.
however you can replace water, have them drink it, have them, put in IV, whatever they can do. There's a drug which is a synthetic ADH will be given, desmopressin. There's also it also comes in a spray. So either subcutaneous, nasal spray, or tablets. So this means the patient will have to be carrying this around. And your complications, of course, is severe hypernatremia and or shock. Patient could go into hypovolemic shock. And here's a summary of your interventions. All about fluid replacement, monitoring. So here's your daily weight, monitoring INO, and managing hyponatremia. Here's your interventions. So the desmopressin, Q, intranasal or oral, fluids either by mouth or IV. Mouth care is included because this does dry your mucous membranes. And then teaching, weight is our most important indicator. Remember, every pound lost here means how much?
Yeah,
How much in
500 milligram.
500 ml, 500
Yeah,
milliliters,
milliliters. Sorry,
and
milliliters.
1 kilogram, that's already a liter. Okay. And that's it. Any question on DI? Let's go straight to SIADH. So this is the opposite. So in DI, you had very little antidiuretic hormone. Now you have so much now. You have too much this time. So total opposite. So because your bloodstream, your serum now becomes very diluted, so you'll have hyponatremia due to hemodilution. So opposite those of diabetes insipidus. So here the urine is so high, the urine output is so much that it leads to a very dilute urine. Oh no, sorry. You have very little urine output here because you have a high level of antidiuretic hormone. So you pee very little, and as a result, the urine that you do excrete becomes very concentrated. So here are your manifestations, include hyponatremia, but it should be enough here. Management. So if we gave fluids and we gave antidiuretic hormone in diabetes insipidus, what do we do in SIADH?
Give a
Monitor.
diuretic.
Okay, we
Monitor
can give
external.
diuretics. Can we give more fluids?
No,
No.
it's gonna make the problem worse.
Okay, so we now do fluid restriction. So less than 1,000 a day. You can replace sodium here because we do have delusional hyponatremia. We can give hypertonic saline, 3% saline. But there's a downfall here because remember, what will be the effect of hypertonic saline? Remember we discussed earlier hypertonic solution?
Mm-hmm.
So according to osmosis, what will happen here if you give hypertonic solution?
Swelling, edema. Cells will shrink.
And as a result, what will happen to the fluid volume?
Dehydration.
No.
For hypertonic, it will be fluid overload.
Okay.
Oh no.
Exactly, yes. The patient will have, it will worsen. It can worsen your fluid overload. Because remember, this patient is already in fluid overload because of all that antidiuretic hormone. So be careful when you're giving hypertonic solutions. So the better option here is diuretics. And here is a demeclocycline. This is an option. Can be used to also promote water excretion in the urine and the kidneys. Again, let's summarize for SIADH. So opposite that of diabetes insipidus. So here we will have fluid restriction. We will promote diuresis by using diuretics and or hypertonic saline, but use that option very carefully. Or you give the meclocycline. All of these increase water excretion in the kidneys. There is a drug you can give in order to increase sodium, but it's not mentioned in this textbook, so forget about it. In case you see it on the NCLEX, it ends in Vaptan, VAPTAN, just in case it shows up on the NCLEX. So there are only two drugs used to increase sodium. It's conivaptan, like coni, CONI, or yeah, conivaptan, or tolivaptan, TOLI, I think. So both Vaptans are administered, but since they can also lead to hypernatremia, these two drugs should only be given in the hospital. There's no patient that will be sent home on Vaptan drugs. Plus, they only come in IV form, so they can't be given at home anyway. Summary of your nursing interventions, same thing. You still monitor your indicators of fluid status. Actions, of course, restrict fluids, give this drug. Saline, again, be careful with this. And institute seizure precautions because the patient has severe hyponatremia. And teaching, please read that. And that's it. Any question on SIADH?
Professor, we're supposed to know
The table.
41.5 block.
This is a nice summary. I mean, if it works for you, yeah.
Okay.
I'm getting the questions on the paragraphs, but yeah, this looks useful. It summarizes it, but just make sure you understand though why it's high and low.
Okay.
All right.
All right.
You want to break or you want to go forward?
If we go forward, will we leave
Break.
early?
Not really.
So
Yeah, let's take 10 minutes. Come back at 11:10.
All right.